Hello students, in this session I'll be briefing you about the systematic way for describing radiographs in orthopedics. The purpose of this lecture or session is to make you able to describe the common radiographs in orthopedics in a systematic manner. The basics of a radiographic description can be summarized in following points, which include first details, that is details of the patient and the radiographic part that is visualized in the film, radiographic film. Then orientation, that is the orientation of the bony part that has been projected in the radiograph. Then adequacy, whether the part that has been projected in the radiograph is adequately projected or not. And then coming to bone and joint, then soft tissue, and then extra. We'll be coming to these points individually. First, details. Here we refer to the details of the patient which are available with us and those which can be predicted by the radiographic anatomy of the bone that has been visualized. The details can include name, age, gender, type and area of the view. Like we are describing the radiograph of pelvis with both hip. This can be the area of the view, and type, whether the view is AP or lateral, then that would be the type of view. And we can include true or non-true nature of the radiograph if we are sure. Then it will also include the date and time of the radiograph when it is available. When details of the patients are not available, we may predict the skeletal maturity and the gender based on the morphological features on the radiographs in some bones. However, do not comment upon the gender of the patient unless specifically asked, because the gender prediction is based on the morphological variations which cannot ensure that the patient is going to be male and female. It just gives the probability. And don't comment on the true or standard nature of the radiograph unless you are double sure. Then after the details, let's first come to the example. So this is a radiograph which is shown on the right side, and the details can be described as: this is an anteroposterior radiograph of pelvis with both hip joints including proximal thigh, both sides, and caudal part of the lumbar spine of a skeletally mature patient, dated 5th March 2020. So these are the basic details which can be delineated from this radiographic projection. And again, we have to ensure that we don't comment upon the true nature of the radiograph unless we are double sure. In pelvis, the true AP pelvic radiograph is defined as having the coccyx centered 2.5 centimeter above the pubic symphysis with symmetrical morphology of both hemipelvis. Here you can see the coccyx is not ending 2.5 centimeter above the pubic symphysis, so it is not a true AP radiograph. So you can comment upon this when you are double sure. Here it is very obvious, so this is not a true anteroposterior radiograph, and you can specify this only when it is asked. Otherwise, just state that this is an anteroposterior radiograph. Then O, that is orientation. Here we have to comment upon the orientation of the bone under question. If it appears to be normal, then comment the orientation appears to be normal. When it is rotated based on asymmetry in horizontal plane dimension, comment the structures appear to be rotated. In pelvis, we can see the horizontal dimension of the obturator foramina and the horizontal extent of the hemipelvis, or we can say iliac bone. And then we have to comment upon the orientation in the frontal or sagittal plane as well, whether the pelvis or any bony part that you are studying, it is tilted in flexion or extension. These parameters can be confirmed by the variation in the vertical extent of the bony landmarks, for example, obturator foramina dimensions. If it appears to be larger in vertical dimension, that means the pelvis is flexed. Why? Because obturator foramen comes in the coronal plane, or it lies parallel to the frontal plane. That's why it is more prominent when the pelvis is flexed. And if it appears to be smaller, that means optic foramen is going more orthogonal to the frontal plane, and therefore its vertical extent will appear smaller. So if the patient is having flexion deformity of hip joint, and when the radiograph is taken, the limb is kept in neutral position or in a slightly flexed position, the pelvis is automatically going into extension to compensate for the correction of the flexion deformity. That means it is going to tilt backwards, or we can say it is going into extension in a simple word. Then we have to comment upon the asymmetry in the coronal plane as well. Earlier we talked about rotation in the axial plane, then flexion extension in the sagittal plane, then the tilt in the coronal plane has to be commented upon. That means we have to comment whether the pelvis is tilted upwards on one side and downwards on the other side, and whether the spine is tilted along with the pelvis or not. So that means we have to comment upon the tilt or deviation in the coronal plane. We'll be coming to the examples and comment only on those variations which are obvious in the radiograph. Do not comment upon the minor changes which may not be picked up well by the examiner, and comment only on the abnormal findings if they are. Now coming to an example. So if we have to describe the orientation of this radiograph, then we have to comment that the left hemipelvis appears to be tilted proximally compared to the right one, and also there is a mismatch in the vertical extent of the left obturator foramen in relation to the right side obturator foramen, which suggests relatively flexed position of the left hemipelvis. I told you that if it appears to be larger in vertical dimension, that means the pelvis is kept in a flexed position. Then coming to A part, that is adequacy. Here we have to comment upon the adequacy of the film for analysis of our zone of interest. If some part of the bone or the structure we are visualizing in the radiograph is missing, then comment that the radiograph is inadequate to comment upon that particular part. And if some part is not properly visualized due to artifact or not clear, then simply comment upon that I am not able to comment on this part because of the poor visualization. Then lastly, comment whether the film is overexposed, that is appearing more black because of the large volume of X-ray beam, or underexposed, which appears to be more white because of less volume of X-rays. And in this example, when we comment upon the adequacy, then the film appears to be inadequate for assessment of left hemipelvis because it has been cut out in the film. And also the film appears to be underexposed because it appears more white, and it is difficult to comment upon the hip joint and the SI joint and most parts of the pelvis that has been visualized in the radiograph. Then coming to the B part, that is bone and joint. Here we have to comment on the most obvious and gross finding which is visualized on the radiograph, and we have to simultaneously provide the details of each gross finding, and every time you have to compare with the opposite side to make the understanding of the pathology better. Then we have to move towards the less obvious findings, and for which we are not sure, comment upon the remaining normal structures. Coming to example, for this radiographic film, the bone and joint part can be described as: there appears to be an obvious irregular lytic lesion in left femoral head surrounded by a sclerotic rim. Here you can see there is a lytic lesion in this area, and it is surrounded by a sclerotic rim, the white part here, and extending superior and medial subponderal bone. It is this part of the subponderal bone and this part of the subponderal bone. This is medial and this is superior, while opposite femoral head has a similar finding but to a lesser extent. Here also we can see some lytic lesion is here which is having a sclerotic margin, and it is also extending to the subchondral bone. It is going up till here. Yeah. So this is the description of the femoral head. Then comment upon the other abnormal findings that you are seeing in the radiograph. So there appears a linear track from the lateral cortex beneath greater trochanter towards the lytic lesion. Here you can see there is a linear track here which is going towards the lytic lesion on the right side. This could be because of the surgical core decompression that might have been done previously, and the track is now visible. And the hip joint appears to be uniform and similar on both sides. That is, the joint space is similar on both sides and it is symmetrical. That means there is no abnormal reduction of joint space in any part of the visualized hip joint on both sides. The joint space on the superior part and the infromedial part is same. The femoral head contour appears to be symmetrical and round on both sides. So the femoral head is spherical here and it is spherical here as well. So you have to comment that the femoral head contour appears to be symmetrical on both sides and spherical. The remaining parts, including the rest of proximal femur, acetabulum, remaining hemipelvis, both SI joints and sacrum, and visualized part of the lower lumbar spine appears to be grossly normal. So you just comment upon the remaining parts, or you can quicken it up by just saying the remaining bony parts appear to be normal. Then coming to the S, that is soft tissue, you have to comment upon the visible soft tissue shadows. Look for any increase in the size and radio opacity of the soft tissue, which could be because of soft tissue tumor mass, could be because of abscess, and could be because of any edema in the soft tissue, which could be muscle, fascia, etc. And when thinner and radio dense soft tissue shadows can be seen, it could be because of contracted and wasted muscles. If nothing obvious, then just comment that soft tissue shadows appear comparable on both sides and no obvious abnormal soft tissue shadow seen on the radiograph. There are some spelling mistakes in this transition, just ignore those. Then coming to example of the soft tissue part. So if we see this radiograph, then we can comment there appears to be no obvious soft tissue abnormality in the radiograph. And in a hypothetical situation, suppose we have got a patient with wasting of the thigh muscles and that part of thigh is visualized on the radiograph, then we can comment the muscle bulk of the visualized portion of the left thigh appears to be reduced compared to the right side. This is just an example. Another example. Here you can see on the left side the soft tissue shadow appears to be more bulky compared to the right side in the supralateral part and the infromedial part. So we can comment there appears to be an increased soft tissue intensity or density around left hip region on its supralateral and inferior-medial aspect. Then last E. E means extra. Here you have to comment anything that has not been described in previous steps and which is visible in the radiograph, which could be foreign body or any device, catheter, etc. Then there is some time for some exercise. This is a radiograph. Just think about it. How would you describe it? So first of all, details. Now we are not aware of the patient details here. Comment that this is an anteroposterior radiograph of pelvis with both hip joints, including both proximal thigh and the lower part of the lumbar spine in a skeletally mature patient. Then coming to orientation. The right hemipelvis appears to be tilted proximally compared to the left side. The right proximal thigh is in adducted position compared to the left side, which is in abduction. The spine tilted towards the left side, along with the tilting of the pelvis. The obturator foramen cannot be visualized on both sides, probably because the pelvis is in extended position and there appears to be no rotation in the axial plane, with both pelvis symmetrically visualized in the radiograph. Then coming to adequacy, the radiographic film appears to be adequate for assessment of both hip joint and both hemipelvis and the sacroiliac joint. However, it appears to be underexposed. Then coming to bone and joint part. So there appears to be gross destruction of right hip joint as understood by the erosions on the articular margins of the femoral head and the acetabular margins as well, with areas of erosion and intervening sclerosis on the articular margin. The left hip joint appears to be normal. Then both SI joint appear to be normal. Both proximal femur appear to be normal. Then the visualized part of the lumbar spine and sacrum also appear to be normal. However, sacrum cannot be visualized completely because of the ball gas. Then coming to the soft tissue. The soft tissue appear to be unremarkable or appear to be normal on both sides, and there's no extra finding in this radiograph. So this completes our description of this particular radiograph of pelvis with both hip joints. You can practice with more radiographs, and once you keep on doing this, you will be fluent in this description. Thank you.